Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for joining the RLS Foundation's webinar titled RLS and Medical Marijuana. My name is Carla Diezenkowski, and I am the Executive Director of the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the many questions submitted with your registration. Dr. Bainbridge will answer as many questions as time allows at the conclusion of her presentation. I'd like to make you all the webinar attendees aware that we are experiencing bad weather in the Austin area at this time. You may experience poor audio quality at times as these storms pass through the Austin area, so we ask that you just stay on the call, and we will just lose reception for a short period of time. After the webinar, you'll receive an email with a link to the webinar recording. The webinar recording will also be made available in the member portal of our website. If you're not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they have RLS or are experiencing a change in their symptoms should always consult a qualified healthcare provider before making a change in their current treatment plan. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a physician. Please visit our website to find a healthcare provider near you. Dr. Bainbridge serves as a clinical pharmacy specialist at the Ann Schultz Outpatient Pavilion Neurology Clinic, an extension of the neurology residency teaching program at the University of Colorado, Denver. She is a professor in the Department of Neurology at the University School of Medicine and teaches at the Skaggs School of Pharmacy and Pharmaceutical Sciences. Dr. Bainbridge manages patients with neurological diseases such as epilepsy, Parkinson's disease, multiple sclerosis, migraine, and RLS. She is currently involved in research projects funded by the CDPHE using marijuana. In her recent past, she has had projects funded by the NIH spanning subjects such as epilepsy, multiple sclerosis, and neuroprotection trials for Parkinson's disease. Dr. Bainbridge, we thank you for sharing your time and expertise with us, and I now invite you to begin the presentation.
Thank you so much, Carla and Zibby. Thank you for putting the presentation together and linking us all together. I'd also like to take a moment to introduce Dr. Matt McKelkey, who's doing a neurology clinical residency or fellowship with me last year and this coming year. So he will also be available to answer questions and maybe interject a few areas that might be of interest to you all. So thank you, Matt, for joining us.
Thank you.
So first of all, I'd like to just talk for 2 seconds about the title, Medical Marijuana and Cannabis. Most patients and individuals or clients who are using marijuana or cannabis products prefer the name cannabis because cannabis will talk and refer to the entire plant or plants. And marijuana, they feel, is more of a slang term. So can be used interchangeably, and I will probably use them interchangeably, but most of the time I'll be referring to medical marijuana as cannabis. We have an interesting agenda. We'll really talk a little bit about the history of cannabis, the components contained within the plant, the different forms, some of the short-term physiologic effects that patients will see with THC containing products. We'll talk about conditions that potentially can be treated with these agents. We'll talk about research and some of the federal laws or guidelines. So basically, as most of us realize, that RLS is pretty common, oftentimes underdiagnosed and a treatable condition. The symptoms can either just be annoying or sensory, motor feelings, creepy, crawly feelings, or they can be painful in some individuals. We know that RLS is a neurologic movement disorder associated generally with sleep. The prevalence varies, 3 to 15% of the general population, and increases with age, although we do know that children are affected as well. More common in women than men. Pregnancy, up to 35% of women will experience RLS during their pregnancy. Diagnosis, there's not a blood test that can tell you that you have RLS unless you have iron deficiency. So diagnosis is typically made based on clinical features. This slide just goes through some of the descriptors of RLS, and basically that comes from our patient population or client-based population of what patients experienced or people experienced with RLS. So the creepy crawly feeling, burning, Elvis legs, flowing water, etc. So the non-medical therapies for the treatment of RLS is basically to gain control of sleep hygiene or exercise good sleep hygiene. Moderate physical exercise is great. Sometimes more strenuous exercise can exacerbate RLS symptoms. Depending on you, hot or cold packs can be helpful, massage, rubbing, stretching, engaging your mind through meditation or yoga, even acupuncture, and eliminating medications that can exacerbate RLS symptoms, and obviously treating iron deficiency anemia if that's part of your problem. Medical therapy in aid of RLS really begins with first-line therapy of the alpha-2 delta ligands, such as gabapentin, Horizon, gabapentin, and acarbil, or Lyrica, pregabalin. And then the dopamine agonists, we know that the dopamine agonists are associated with augmentation. That would be like Mirapex, Requip, the Nupro patch. Benzodiazepines can be helpful, although we have to be careful when using benzodiazepines, and often staying away from them as long-term use. Opioids, iron, levodopa, carbidopa, and then other agents such as anti-seizure medications or cannabis. Cannabis has been around for a very long time. Basically in the 19th century, marijuana was legally grown and utilized in the United States. Moving into the 20th century, in 1937, the Marijuana Tax Act was passed, and it prohibited all use of cannabis on a federal level. In the 70s, the Controlled Substance Act was passed, prohibiting cannabis federally, and that made marijuana a Schedule I drug, which means there are no medical indications, and the potential for use and abuse can be high. In the 21st century, in 2014, the United States House of Representatives passed a bill prohibiting the DEA from using funds to arrest medical cannabis patients in states with medical laws that surrounding cannabis. And currently, many states either have decriminalized or legalized medical marijuana and or the use of recreational cannabis. If we look at the different types of cannabinoids or cannabis, two sort of main plants, sativa and indica. We usually think sativa may have a little more stimulatory effects as opposed to indica. So indica, I've been trained to think into the couch. So indica containing products tend to be a little more sedating. Now I will tell you that many, in Colorado, we have both recreational and medicinal or medical cannabis, and many or much of what we are seeing in Colorado are actually hybrids, so they will contain sativa and indica. So if we just look at cannabinoids, cannabidiol, we abbreviate as CBD. And the big difference between CBD and delta-9 tetrahydrocannabinol, or THC, is CBD is non-psychotropic, so it does not, you won't experience the high, whereas THC is psychotropic and you do experience a high. The mechanism for CBD is somewhat unknown, although I think we're getting a little closer to thinking we know how it works. We know what it doesn't do. We know it does not bind to the CB1 receptor, and it may be an antagonist. If you look at THC, it's a partial CB1 agonist. So you can see that they have different effects, and they may actually be helpful together to maybe bolster the effect of one or the other. And specifically, we're usually thinking a little bit of THC may be helpful in the efficacy of CBD, but we don't really know yet. We do know with cannabinoids that there are the potential for drug interactions. If we just look at the plant-based chemical, pretty diverse. Cannabis sativa has more than 480 known constituents. 70 of them are cannabinoids, many different cannabinoids, even ones that we don't know about yet. And the remainder may cross the blood-brain barrier and have neuroactivity, such as aldehydes and ketones. Exogenous cannabinoids can be consumed in many forms. So we know that there's cannabinoid rich preparations. That's the herb or the plant-based material, marijuana or cannabis, and it can also be in a resin form. You can also see cannabinoid containing pharmaceutical products containing natural cannabis extracts like Sativex, which is produced by GW Pharmaceutics. That's also Greenwich Pharmaceutics in the United States. Also, Epidiolex is also produced by that company, and very interestingly enough, is now at the FDA level, potentially awaiting approval. It does have an approvable letter by the FDA subcommittee, and that's for Epidiolex, which is CBD or cannabidiol product. So we're hopeful that that product will actually become available soon, or FDA, at least FDA approved soon. And then there are synthetic cannabinoids like dronabinol or several other products that we've had on our market. So as I mentioned, diverse chemicals that we're dealing with here. So there are the potential for drug interactions. We know that cannabidiol, if you look at the pharmacokinetics, it's sucked into fat very easily, so it's highly lipophilic. We know that it distributes through the body pretty readily and quickly, and it's highly protein bound. These are all things that we look at, or sort of pharmacokinetic parameters that we look at, and we can predict that there will be drug interactions because of what we see with some of these pharmacokinetic principles. And we also know that it's extensively metabolized by the liver, so it utilizes the cytochrome P450 system, either 3A, 2 or 4, and 2C, 9, 19, and 8. The half-life of CBD is anywhere from 18 to 32 hours. So that's quite the span for the half-life of that particular product. We know that it can affect other drugs, as I've mentioned. It can be an inhibitor of some of those metabolism agents in the liver. So we can see other medications, especially some of our anti-seizure drugs, their serum concentration increasing, which may lead to a decrease in those particular medications, their dose. We also know that chronic administration, so used on a regular basis or habitual basis, may also induce some of the cytochrome P450 isoenzyme substrates, therefore affecting some of our other anti-seizure drugs such as clobazam. Warfarin, you will see an increase in the serum concentration of warfarin, and that's especially if you're using a CBD and THC type product, so that you would be at a higher risk of bleeding. Obviously, we follow warfarin with blood tests, INR tests, so you can determine if somebody's at higher risk of bleeding. So back to the forms of cannabis, we have the leaf that can either be eaten as edibles, smoked, or vaporized. You can look at plant resin, which can either be smoked or eaten, oil extracts such as Sativex, which is nabiximols. There's single molecule preparations, just pure THC, like you see in Marinol, which is a prescription product that has been on the market for several years. Dronabinol as well. And there are liquid formulations, as I've mentioned. Epidiolex is a liquid formulation, which is purified CBD, and has been used for the treatment of pediatric epilepsy. And it's generally, we're talking about catastrophic epilepsy, meaning hard to control seizures. And as I mentioned, Epidiolex does have an approvable letter from the FDA subcommittee. So we're awaiting FDA approval, that should be, not spelling typo there, soon. The routes of administration are very important when we're talking about these products. So if you're inhaling or smoking cannabis, you definitely see the effect much quicker in 3 to 10 minutes. Whereas if you're ingesting it, you're looking at 1 to 3 hours, because cannabis does have a high first pass metabolism. So the absorption is very variable. And I would exercise caution when we're talking about the edibles or the cookies that are intended to be sliced into sometimes 8, sometimes 12 pieces. And bud tenders will tell people to take, 1 slice of the cookie and wait 20 minutes. And if they don't have an effect, then they take another piece of the cookie. And so oftentimes, because here in the United States, that's not how we eat our cookies. We eat 1 cookie, 2 cookies, not a little sliver of cookie and then wait and then eat another sliver. So we see that some patients see a big boost of effect when they weren't anticipating that. So oral ingestion is very variable because of the high first pass metabolism. Inhaled or smoked, you basically see the effects much sooner and much faster. So here on this next slide, we see some of the preparations that you actually can make or buy in some of our plant-based dispensaries. So you can have the dried flowers, you can have a hashish oil or a tincture, a hash oil. You can actually see on the bottom right the vaporizer, the detachable balloon that fills with vapor. And that is a very effective way to consume these types of products. The vaporizer is it's expensive to buy, but it's kind of a one-time shot. And you actually see serum concentrations pretty quickly after inhaling the vapors filled within the balloon. One of our research products or research trials right now is utilizing a volcano vaporizer. It's a back pain study where we're comparing an opioid with a cannabis-based product from the government. So this next slide is consumption. Again, smoking, vaporizing, or eating basically has to do with burning the herb when we're talking about smoking. If you're smoking, it creates smoke. You see effects after about 10 minutes. However, it's bad for your health to be smoking. So you actually see that there are combustibles when you're smoking. Vaporized products, it's a better way to go because it heats the product or the herb before it burns, so creates a vapor. Again, you're still getting that effect pretty quickly. Eating, you're swallowing the herb, so you're really not heating it. And basically that's where you have the high first pass metabolism. It takes longer for an effect, and the effect can be very variable. Potency, when we look at neurologic disorders, we have to think about everyone's metabolism and tolerance is a little bit different. And you have to to think about that, and maybe talk to somebody who is knowledgeable about these products and your specific condition to help guide you, and you can use the products correctly and safely. Again, the dosing changes of marijuana or cannabis can be based on a patient's therapeutic response. When you're looking at short-term physical effects of THC containing cannabis, one thing that we see are the eyes become red. There's a decreased intraocular pressure. Your mouth becomes dry. Your skin, the sensation, you can have a sensation of cold or heat. You actually see an increase in your heart rate, which can be problematic in some individuals. So this is THC containing cannabis. So there's also something called heart rate variability, where you can see that your heart very variably changes the way it's beating, or patterns, and your muscles become relaxed. Conditions potentially that can be helped with cannabis type products would be sleep issues. So that would potentially include RLS, pain treatment, anxiety, although that's a double-edged sword, because THC combining products or containing products may actually increase anxiety, at least after some use. It can be used for nausea and vomiting, especially in cancer patients using chemotherapy. Some of the products can increase your appetite, especially if you're talking about THC products. As I mentioned, you can decrease intraocular pressure, which may be helpful for glaucoma. And in some patients who have a lot of spasticity, so patients with multiple sclerosis, spinal cord injury, cerebral palsy, that it may be helpful for treating spasticity in those individuals. And then we mentioned epilepsy. So research is really, there's a lack of good research here in the United States, mainly because it's still federally illegal. So it's hard to get funding. And that's been one of my hurdles here at the University of Colorado. And we have to pull in what other research has been done, such as in Europe, to make decisions on how to use these types of products. Private entities in the United States are beginning to conduct marijuana-based research. And again, one major problem with current studies is that they're using standardized they're not allowing us to use standardized preparations that our patients are, at least in Colorado, obtaining from a bud tender in one of the dispensaries. So we have to use very specific products that are accessed from the government. Now there are ways around this, which we're getting kind of creative. So we do have a van that's actually going around and conducting some research on what patients are actually taking from their medical dispensary or dispensaries here in Colorado. There was a house that was just purchased near our campus, and some research will begin in that house. It's off campus, so patients can take whatever. We're doing a driving simulator with that particular way of doing research. So if you look specifically at RLS, there's not a lot of good information or well done information on patients with RLS. However, you'd go back and look at people who had pain, because some patients with RLS have pain, and many patients have problems sleeping. So we can go back and make inferences on patients with those conditions in other studies, and kind of speculate how that would be helpful in some of our patients with RLS. So the association between medical cannabis and opioid use in chronic pain. So this is basically just leading into some of the research that's actually been published. This is probably, this is a not strong evidence trial. It was done in New Mexico on about 70 patients. They were looking at population-based patients with chronic pain, and they saw a trend in decreasing their opioid use when using medical cannabis to treat their chronic pain. Again, not strong evidence. The number of patients was pretty low, so more research needs to be completed in this arena. Again, on the pain side, cannabinoids for chronic non-cancer pain. So this is a systematic review of randomized trials, 18 studies that were looked at, and they looked at extracts, they looked at THC, they looked at smoked cannabis products. So it was a lot of different clinical trials rolled into the recommendation from this systematic review. Basically, they found that 15 out of 18 reported improvement in pain, and this is studies, and 4 out of 18 reported improvement in sleep. So there's a limitation to this type of study using a systematic review because you're going back retrospectively and looking at what other trials have reported. We actually do have a back pain trial, neck and back pain trial going on now, where we're looking at vaporized cannabis and crossing patients over with an opioid and a placebo to see if we can affect their pain level and decreasing their pain with cannabis. Another systematic review, well, this is the meta-analysis of cannabis for chronic pain. Again, there were 18 trials, double-blind, randomized controlled trials that compared cannabis to placebo in patients with chronic pain. This study showed, or these studies showed, that cannabis does have a moderate effect for the treatment of chronic pain. Again, more studies need to be done. Pain and sleep research, smoked cannabis for chronic neuropathic pain. These are adults with neuropathic pain randomized to receive cannabis at 4 different potencies for 14 days and then crossed over. And their average pain was measured using an 11-point scale. The study actually indicated that single inhalation of 25 milligrams of 0.4 THC cannabis 3 times a day for 5 days significantly reduced the intensity of pain, and it was also improved their quality of sleep. Again, another research trial looking at sleep. This was another systematic review, 39 trials, various formulations, either smoked, oral, etc. The information provided did not allow for strong clinical decisions to be made. The results of the study were mixed, really, but nonetheless showed that cannabis does affect sleep. And that's more of the THC-based products. So we need more research. That's the bottom line. At the University of Colorado, we will have a clinical trial, hopefully, that opens up. I will be involved in that trial, and that will look at using cannabis in patients specifically with RLS. So more to follow and more to come on that. So federal law, marijuana is still a Schedule I drug under the Federal Controlled Substance Act. So it makes possession, purchase, sale, and cultivation illegal. Crude marijuana may not be prescribed, administered, or dispensed. So that is part of the hang-up and problem with doing good research in big academic centers. Other drugs that share the Schedule 1 schedule would be like LSD, heroin, ecstasy, etc. So it's important to know what's happening in your specific state. This information has recently been updated. We have 29 states and excuse me, and DC that has medical marijuana approved, and there are several states that have recreational marijuana. So it's important to know what's happening in your specific state. A number of states have various approved medical conditions, and it's interesting. So you see this big list: glaucoma, nausea, pain, Parkinson's disease, PTSD, cancer, and I have next to them the number of approval places where it's actually written into this is an acceptable medical condition. And there's not a lot of evidence. There's some evidence, but there's not a lot of great hard evidence behind any of these medical conditions. So current legislation can be misleading. It's important for consumers to know that there's not a lot of good evidence in which products treat which condition. And cannabis alleviates symptoms, but really doesn't actually treat the disease. So you have to think about that before consuming the products. It's not actually going to cure the disease, it's going to help with symptoms. So we're talking about multiple sclerosis, cancer, HIV/AIDS, Crohn's. There's some also, there's a small level of evidence in the AD or Alzheimer's disease group where cannabis may be decreasing some of the plaque found in those particular patients' brains. So the jury's still out, though we don't really know. But it's important to know the difference in the fact that we're not treating a disease, we're treating symptoms. So guidelines, the American Academy of Neurology recently went back and reviewed, the systematic reviews, the meta-analysis, any clinical trials for the use of cannabis in the treatment of multiple sclerosis, Parkinson's disease, Huntington's disease, tics, and Tourette's syndrome, dystonia, and seizures and epilepsy. It had the strongest evidence for the use of oral cannabis extract pills from the pure CBD to lessen spasticity. And there was moderate evidence of THC pills and oral spray to lessen spasticity and painful spasms. So that particular product for spasticity may be one of the GW or Greenwich Pharmaceutics products. We have to think about lifetime addiction and risk with use. So on the x-axis, we have nicotine, heroin, codeine, or cocaine, alcohol, and marijuana. Marijuana addiction risk in the teenage population is the same as we see with cocaine, and that's in the teenage population. Actually, what we find is in adults, about 6 to 9% of patients become addicted. And in the pediatric population, or pediatric adolescent population, it's more like 16%. Reason for that is brain development in adolescence, age on the x-axis, functional development on the y-axis. And we find that the brain is not fully developed. The prefrontal cortex is not completely developed. So teens have a lot of impulsive behavior and immediate reward in the limbic system, and they don't have a lot of the stop signs, so the cortex being developed, thoughtful behavior, and long-term gain. So that ends up being risky behavior. So you're basically talking about the reward pathway when you're talking about addiction and pleasure, the pleasure center of the brain. Many patients with RLS recognize the dopamine system as being a pleasure system, and so does everyone else. I like to buy shoes, all right? That hits my dopamine pathway on a regular basis, and I like it. It makes me feel good. And basically what you find in the adolescent brain is that you can't pull away from that increased dopamine in that reward pathway. So it can be a problem in the adolescent population. There is one particular study that's interesting when you look at persistent cannabis users and neuropsychological decline from childhood to midlife. Basically, they studied in this particular trial about 1,000 patients, and they looked at IQ scores. And basically what you're finding is that people who habitually used cannabis over a long time span from childhood to midlife, you find that their IQ points decreased by about 10 points. So if, average is 100 IQ, going down to 90 can be a problem. Now, if you're at 160 IQ, dumbing down to 150 might not be so much of a problem, but you need to know that up front. So you can see a decline in IQ points. You can also see impairment in learning, memory, and executive function. Older adult data, this is kind of interesting. So the at least one study looked at substance abuse in elderly patients, or advanced age, I should say, is rising. There's multiple reasons. Many people are dealing with coping mechanisms. A loved one or spouse has passed away. The thing that we don't know, or the thing that we do know, is the brain continues to change even in the advanced years. So we don't know how these substances will affect abuse. And this wasn't just marijuana. This was many different substances like cocaine, etc. They actually collected this information from emergency departments. So they asked the question, if the patient came in and they were 55 or greater, have you ever used certain products? And I just pulled the marijuana out. So marijuana went from 300 to 1,700 patients using, and that was the time frame between 1995 and 2002. So I've collected some of the frequently asked questions. It was really nice of your executive director and her amazing team to solicit questions for this particular presentation. And one question that kept popping up is, how can I get medical cannabis or marijuana in my state, or what doctor can prescribe it? And you really have to go back and look at the laws of your state. And medical marijuana, there are doctors who can give a medical marijuana card that can be used at dispensaries. So it just depends on your state. One thing that I think is interesting is that many of our practitioners don't have a lot of knowledge about these products, and we're trying to change that. We're trying to educate practitioners across the globe on these products so that they can answer questions that their patients may have on these products. I do think it's important, though, that you get your information about these products not from the bud tender, because that's where a lot of our patients are receiving their information, is from a dispensary. And we recently did a study and found that dispensaries were recommending even THC containing products in pregnancy for nausea and vomiting, and that's not a good thing to do. So we think it's important that you ask your healthcare prescriber and practitioner. And I know we have another question that's kind of related to this, and what's a good way to introduce this question to your primary practitioner? And I think the best way to do it is just ask them if they would recommend medical marijuana or cannabis for your situation, and I would ask their level of knowledge, and if they don't have a good fund of knowledge, then I would ask them if they can refer you to someone who does. Your pharmacist may also be pretty helpful when talking about these particular products. And how does cannabis, or does cannabis-based oils do anything? According to this one study, yes, maybe. This was a double-blind, randomized, placebo-controlled trial, and it looked at THC CBD spray for peripheral neuropathic pain. There were clinical improvements in pain and sleep quality with the spray, but the study did not show a statistical improvement. So it might be helpful for some patients, but perhaps not for others. And really, you have to go back to the squeaky wheel gets the oil, and that each patient should be an individual, and talk to your practitioner about what might be helpful. I can tell you that some of the topical oils, not for ingestion, but just using for a localized muscle pain might be fine, but you should not see a lot of systemic absorption in the body with those particular oils, unless you're ingesting them. And what is new with the approval of cannabis? And I've already talked about Epidiolex as an approvable letter. Interestingly enough, the FDA in the recent past, or the past actually, has never gone against the FDA subcommittee, in which they unanimously voted for Epidiolex, which is purified CBD from the plant-based, from the plant for catastrophic epilepsy. Is marijuana or cannabis effective in treating RLS? We're unsure due to a lack of evidence. So I would go back and look at some of the sleep studies or pain studies to kind of make a decision on that. How can you get involved in studies for its use? I would go to clinicaltrials.gov. As I mentioned, here at the University of Colorado, we will have, hopefully have, a study in RLS. It'll be interesting to see if that study will be CBD or a THC and CBD study. So it may be that we need a little bit of that THC with the CBD. It might be that we need a blend, and we certainly don't know the ratio at this point in time, because we don't know exactly what causes RLS. So I guess at this point in time, I can go through some of the questions. Carla, if you want to ask some of the questions, you're more than welcome to. I would definitely say that talk to your healthcare provider before making any changes to your treatment. There definitely are drug-drug interactions that we do see with CBD and THC containing products. So it's important to recognize those and get seek medical advice.
Well, thank you, Jackie, Dr. Bainbridge. This was a really great presentation. I just want to let everyone know we've had over 30 people add on through this webinar. I mean, this is a packed house today, so we're pretty excited. So I wanted to ask you a question, and I'm going to combine it because this was another common question. Is it safe to use medical marijuana with alpha-2 delta ligands, opioids, or dopamine drugs, since these are all common therapies used for RLS? So I'll wait for your response.
Sure, that's a really interesting question. If you're looking at pharmacokinetic interactions, probably there are no pharmacokinetic interactions that we know of now. Matt, do you want to say something? No? Sure? Okay. But one thing that we do see is something called a pharmacodynamic interaction. So if the product that you're using, and if you're taking something for RLS and you have sleep problems, it makes you tired. And so some of our drugs, such as the alpha-2 delta ligands, The opioids both cause sleepiness, and some of our dopamine agonists can also cause sleepiness. So what you may see there is you may have more of that tiredness or sleepiness. You're probably going to see more of that with the THC combining products as opposed to the CBD, although you may see a little bit of that with your CBD products.
Okay. Is weight gain a side effect of cannabis use?
So weight gain is a side effect of THC components. So, and that's one place we do use it for wasting, such as in HIV/AIDS or cancer patients. So it will stimulate appetite if you have a THC combining product. Now, I will say that the CBD products may cause some people to not eat as much. And there is something that's basically that we see with THC, especially smoking those particular products, and that's cyclical vomiting or a GI distress.
Okay. Are you still there? We're having a little bit of breakup on the call.
Yes, I'm still here.
Okay. Sorry, everyone, if you're hearing this. Next question. How effective are cannabis balms? BALMS.
Yes.
Sorry, I have a Pittsburgh accent.
Yes. That's so funny. So the balms are effective if you're using them for something topically. So like if you have a muscle strain or arthritis, that can be very helpful on, joints. But you're not taking that or thinking that's going to help with, putting you to sleep.
Okay. How effective is medical marijuana for people in recovery from alcoholism?
Yeah, that's an interesting question. And a purist sample would probably say that that's a bad idea because you're switching one drug for another drug. And yeah, they're all depressants in the central nervous system. Now I would say we have no idea really. I can tell you that for opioid addiction and some other addictions, they are recommending therapy with medication assistant therapy, which is using agonist, antagonist type products for that group of people. Marijuana may be helpful potentially in that group of people, or cannabis, but we don't know about alcoholism and cannabis, but they're both CNS depressants. So the jury's out. Don't know.
So I guess I'd keep an eye on, clinicaltrials.gov, since we're seeing more states approve it and, there are other options, with the government might change, that there might be some studies in the future on that.
Yes.
Okay, is it truly how it is ingested or the type of cannabis used that appears to be a variable and successful treatment?
That's a great question. I would go back to the route of administration. So we definitely see with vapor or vaporized cannabis, especially obviously plant material, you see the highest serum concentration and most reliable. Within minutes, you're getting the efficacy as opposed a few minutes as opposed to several minutes. Or if you're looking at the oral products, that can be an hour or longer. So because of the high first pass metabolism. So it's I would say when you're looking at efficacy, it really depends on the route of administration.
My family nurse practitioner says CBD oil that is not tainted with THC is made by the federal government. Who sells it, and is that true?
So, yeah, if you're talking specifically about hemp oil, and hemp oil comes from an industrialized hemp plant, and by nature, that you can make clothing out of rope, and by definition, that should be no more than 0.3% THC. That actually can be distributed, across lines because it's non-psychoactive. Now, going back to that government statement, basically, you're now talking about stuff that is coming from Ole Miss, and basically they do not have a CBD product that's purified for use. So that actually, we're going to be using that particular product in one of our clinical trials, and we actually have to make it into a product that can be consumed. So I'm compounding that particular product from the government. If you're specifically talking about cannabis-based CBD. So different when you're talking about the hemp, industrialized hemp product or hemp oil that can go across state lines, and it's no more than 0.3% THC.
So
it's also food product.
Okay. Jackie, just to clarify, so only a pharmacist can compound that oil?
Oh.
Yeah.
Yes.
Because there are compounding pharmacies throughout the United States. And so I thought that, I'm just curious, if you're in a state where this is legal and you get, prescribed this product, it would have to be compounded.
And that's really interesting. And no, they cannot purchase the product. A pharmacy cannot purchase the product. I'm only, Matt and I are allowed to compound this particular product because we're not affiliated with the hospital. We're not affiliated with a private compounding pharmacy. And we've done other clinical trials with cannabis. So pharmacists cannot compound the government product because it's still federally a Schedule I drug.
Okay. Good clarification.
We're just special here.
You are. It's Colorado. But I just was curious. I had to ask the question, because this is a popular topic for the RLS community, and I wanted to make sure we understood how you could do this.
Yeah. Now dispensaries have CBD containing product. I would just say that people need to be cognizant of what they're actually purchasing, and making sure that they're working with a reputable company. And it will be interesting to see if the FDA approves Epidiolex, which is CBD. In clinical trials, we used that particular product, and still are using it. And it was a sesame seed based oil. It will be interesting to see, what happens with that product. I know that in Colorado, many of the there was actually a bill floating around in Congress that wanted it to be not able to be in the hands of pharmacists, that it had to come from a dispensary. And I think that's the wrong way to go about this, because we know that CBD has many drug-drug interactions.
Right.
So it's a problem, and it's going to need to be monitored. It will be very interesting also to see if it does get approved by the FDA, which I'm pretty positive, or I'm pretty hopeful that it does get approved. Just based on the subcommittee's recommendation. But it'll be interesting to see what the DEA does in terms of scheduling that particular product.
And there seems to be a huge lobby with the epilepsy community to see this, to have this go through as well.
Absolutely. Definitely.
Okay, we'll move on to the next question. What type of cannabis would be most helpful for the trifecta of RLS, insomnia, and depression?
Yeah.
These are good questions.
They are good, very
I
good questions. And I wish I had the magic bullet for that. And I guess if you just stopped, and talked about sleep and RLS, you would say maybe, more heavy on the CBD with a little tincture of THC in there. But then if you're pulling in the depression side, that we don't know. You just don't know about that. Oftentimes with depression, you find anxiety, and we know that a lot of the CBD or the THC products, excuse me, opposite of what I was going to say, THC can actually make anxiety worse. So then does it make anxiety and depression worse? That we don't know, but this is a really good question. CBD may be more helpful for people with anxiety, but you have to be careful about what you're doing with the dose. So it might be the answer is CBD with a little tincture of THC just to kind of have an entourage or bolstering effect of the CBD product, or activating effect maybe. But we don't know. Jury's still out. Good question. I hope next time I can answer that question.
Mm-hmm. Why does CBD oil help some people with RLS but makes it worse for others?
Because everyone's an individual. And we don't know exactly what causes RLS. I mean, we have ideas, but we don't know that it's the same in every single person, or the pathophysiology is all the same in every single person. So what might be good for some person might not be the best for another person. So it might just depend on the pathophysiology of the RLS for that individual person. So, maybe with a pain effect, maybe you need more of the THC side, or CBD and THC, and we just don't know for sure.
Okay.
And it could be if somebody's taking CBD that they may need a little THC for an entourage or a bolstering effect.
Okay.
Sorry, I cut you out.
No, that's okay. We'll go to our last question. Are you currently doing any RLS research that involves the use of cannabis?
So specifically, one of our researchers, Dr. Leahy, I'm actually working with her, and we're also working with Matt, who's sitting here with me, on a large trial looking at RLS patients. So we're just in the development phase of that particular grant right now.
Will you be posting on clinicaltrials.gov?
Yes, we absolutely will be.
All right. So RLS patients can look to that. Do you have to be a resident of Colorado to participate in the study?
You probably have to, I'm not sure yet, but you probably have to be here.
Okay.
Yeah.
You can't take over state
Because you won't be able to take the product over state line.
Okay. Okay, so that's a great one. But I thank you for this really informative webinar. We've had everyone stay on the line today. This has been really popular. But I want to remind everyone of our next webinar on Wednesday, July 18th with Dr. Sergi Ferry, where we're going to talk about the essential role of adenosine in RLS. That was a very popular session at the sleep meeting this year in Baltimore, and you'll get to hear what Dr. Ferry has done with his RLS Foundation research funds and their next steps with their research. Well, Jackie and Matt, I thank you again for being with us today.
Thank you so much, and thank everyone for great questions and hanging on the webinar.
All right, thank you. Have a great afternoon.
You too. Bye-bye.
Bye-bye.